recording this webinar. So if you're watching this in Enduring format, all the disclosures are the same, but the expiration date will be July 31st of 2021. All of you that are attending live here will receive an email after the webinar from GoToWebinar. It'll say something like, thanks for attending, and it will have a SurveyMonkey link in there. That's your evaluation. So if you want to receive contact hours, complete that evaluation, and that will give you your certificate. But any issues or questions, just let me know. I am going to introduce our speaker. So I'm really excited to introduce Susan Salisbury. She is the system lead for safe patient handling and mobility for Ohio Health. She's presented programs locally, statewide, and nationally on transitional work, ergonomics, and safe patient handling, mobility, and falls prevention. She's a passionate lifelong learner with her goal to present evidence-based practice for the health and safety of both patients and healthcare workers. So Susan, I will turn this over to you.
So Jessica, do you have the slides or do I need to pull them up?
I can pull them up, but if you want to have control over switching them, then I would pull them up on your computer.
Okay, let me take a moment to do that. Sorry.
Sure,
I
no,
did
that's
not clarify that in the beginning. So that goes
okay.
to...
And just a reminder for everybody who just signed on, I do have all the attendees muted. It helps decrease that background noise that we get. So any questions or comments, use the chat box or the question box, and we will answer them that way.
Mm-hmm. Nuts. Come on, all the way down. No, I don't want that one. Can I minimize this? There we go, so I can see what I'm doing. Come on. I apologize, technical difficulties. Give me just a moment.
It happens to us every time. Anyone who's taken a webinar with us knows there's just always something that comes up. And if you can't find them, Susan, I can pull them up and just
Here
follow along.
Just needed to. And here it is, and it is this one right here. Okay, and I'm going to do it in this mode. No, I don't want to leave the webinar. I just want to get rid of this screen. Jessica, how do I get rid of the screen?
I can see the slides. I see like black bars on the side, but we can see them.
Okay, well, that's good enough. It's just, I know that as long as you can see the slide, the webinar piece that has the show the screen, stop showing, all that is taking up 1/3 of my screen. So I was trying to minimize that, but I don't want to disconnect. So we'll just go from here.
Gotcha.
So first of all,
I can see it.
Okay, well, we're good. First of all, thank you very much for the invitation to do this presentation. I am absolutely passionate about safe patient handling and falls prevention. I've been on my journey with Ohio Health for 15 years. I'm an occupational therapist by profession. I'm also a certified disability management specialist, and I'm a certified safe patient handling professional. So I really, my passion evolved because my role started as the occupational therapist within Associate Health. So I would work with associates or healthcare providers that would get hurt at work moving their patients. And I said, this is crazy, this is nuts. We've got to look at how we can do things differently. So I'm going to share with you some of my journey and what I have learned in my last 15 years of practice, and I think we're really moving forward nationally at looking at integrating not just patient handling injuries, but fall prevention and mobility, because we know it's all very important and it's all integrated and it all looks at that patient outcomes. So I do work for Ohio Health. You always have to give a pitch for your employer. It's a not-for-profit charitable healthcare organization with Methodist roots. It's here in Central Ohio, and I think now we're up to 12 or 13 hospitals and almost 30,000 associates. So it's a great place to work, and I'm grateful for these opportunities. This is an evidence-based presentation. One of my mentors, Inga Zydvinskas, really, I have to shout out to her because she got me engaged in evidence-based practice. As an occupational therapist, I'm older, and way back when we started school, we didn't do evidence-based practice. So it was through my relationship and my mentoring from my nurse buddy that I really learned about the importance of evidence-based practice. And she's the one who got me into the literature, and she's the one who said, let's look at why we're doing what we're doing. So objectives for this presentation today, I want you, by the end of my webinar, I want you to be able to identify the relationship between caregiver safety and patient safety. I want you to be able to speak to the evidence that supports recommendation for safe patient handling and falls prevention, because they do go hand in hand, and then look at strategies for both falls prevention and safe patient handling. So if we really talk about a safety culture, it's really looking at how we can integrate all these initiatives. I had the pleasure of working with Joyce Black, who is a professor of nursing, University of Nebraska, and Kathleen Volman, who has her own company but is a very, very skilled critical care nurse. And we collaborated together and really looked at how can we need to stop siloing all the different committees. I know most healthcare organizations will have a falls committee, and then they might have a pressure injury prevention committee. They might have a early mobility committee, and they might have a safe patient handling committee. But if we really look at integrating all of those forces united, we're going to impact outcomes, because we know mobility is medicine. We know that if we move our patients sooner, we're going to improve their outcomes. We know that if we move them safely, we're going to decrease their risk of falls, or we're going to decrease the risk of pressure injury. And so really looking at how we can work collaboratively on all these initiatives at the same time really does promote that safety culture for both the patient and the healthcare worker. So when we look at ergonomic risk factors, ergonomics is the work, the worker, and the workplace. And again, I had the opportunity to work with a group of national subject matter experts and really trying to drill down what are those ergonomic risk factors for patient handling injuries. The first risk factor is exertion. What's the hardest thing you do as a bedside nurse? And usually I have an interactive portion with my presentations, but I'll share with you when I ask people to raise their hand and say, what's the most forceful thing that you do all day? And it's that boosting and repositioning patients, and we know our patients are getting larger. The second risk factor is repetition. And again, when I present live, I ask people, what do you do all day? If you're a bedside nurse, you're boosting, you're repositioning, you're turning. Posture, the third ergonomic risk factor. What are those awkward postures, those crazy positions you get in as a bedside nurse? And many people have shared different stories. And if you're not lucky enough to have single patient rooms, just even maneuvering within a room with 2 beds and all the additional equipments. And then duration of exposure, the last risk factor. That's how long have you been doing the work that you're doing? Have you been a bedside nurse for 5 years, 10 years, 15 years? Do you work 8-hour shifts, 10-hour shifts, 12-hour shifts? So really looking at how all of those risk factors, the exertion, the repetition, the awkward postures, the static postures, and the duration of exposure, they all work cumulatively to increase your risk for a patient handling injury. Typically, it's not that one time you boosted Mrs. Smith up in bed. Typically, it's a combination of all those factors in together. So when we look at work-related musculoskeletal disorders, those are your injuries to your muscles and nerves, tendons, joints, cartilage, and discs. These are those injuries where the work environment contributes to the condition, or the condition is made worse because of the work condition. They're not your slip, trips, and falls. Those can still be OSHA recordables, and they're not your needle sticks. But these work-related musculoskeletal injuries, when we think about in your neck, how many nurses go home with a sore neck, a cervical sprain, or a rotator cuff tendonitis, or a lumbar strain, or any of those musculoskeletal parts of your body that are at risk when you're boosting, turning, repositioning, and taking care of your patients. This was a great study done by GOMA. It was the Occupational Health Safety Network, and it looked at injuries among workers in U.S. healthcare facilities from 2012 to 2014. And of those 112 U.S. facilities, they reported almost 11,000 OSHA recordable injuries. OSHA, the Occupational Safety and Health Administration. Almost half of those injuries, 4,674 injuries, were from patient handling and movement. So that put the rate of patient handling injuries at 11.3 per 10,000 worker months. Patient handling injuries were highest among nurse assistants and nurses, and the most frequent injury tasks were the boosting and repositioning in bed, followed by lifting and transferring to bed or chair. So again, if we look at injury statistics, why is this significant? Healthcare workers are one of the most at-risk occupations for musculoskeletal injuries, and that's cited from the Bureau of Labor and Statistics. Patient handling tasks, those boosts, turns, and repositions are the leading causes of injury. In the 2013 Bureau of Labor and Statistics research, the rate of musculoskeletal disorders for healthcare workers was 56% higher than the rate for all other private industries. And more than 1/3 of back injuries in nurses are associated with manual patient handling, and that came from the ANA and the nursing world. So this information, incidence and cost, is from Aon. Aon is a leading global professional services firm that provides a broad range of risk, reinsurance, retirement, and health solutions. They use data analytics to deliver insights that reduce risk and improve performance. In their 2016 Workers' Comp Barometer, they really looked at what was the incidence and costs related to work-related musculoskeletal injuries in healthcare workers. The most frequent injury was the back at a 51.3% incidence, followed by the shoulder at a 20%. And if you look at the associated costs, you can see that the shoulder was a higher injury cost than the back. And if you think, as nurses, you know, when you think about the shoulder, it is a much more complex joint with flexion, extension, internal and external rotation, abduction, and adduction. What they also showed in this study is that healthcare organizations that followed the ANA interprofessional standards for safe patient handling and mobility and those that were employing certified safe patient handling professionals had a significant reduction in their workers' comp costs. So again, this is just to give you a flavor of why this is important. So this is one of my favorite slides. Would you agree with the statement that healthcare is the only industry that thinks 100 pounds is light, right? I know I used to work at Kroger's before I was an occupational therapist, and I had a dolly and rollers and a forklift and a power jack to move my product. But what do we have in healthcare? We have a Chucks. It's crazy. Any other profession uses assistive devices when they move heavy items. And again, this looks that the nurse assistants were the second highest group of work-related musculoskeletal injuries, and nurses, you made the top 10, you were number 6. PSAs or nurse assistants were second only to material freight handlers. Again, looking at incidents from the ANA survey in 2013, 8 out of 10 nurses work despite experiencing musculoskeletal pain. So 80% of nurses are working with back pain. 62% of nurses are concerned about developing a disabling musculoskeletal injury. 56% of nurses report that their musculoskeletal pain is made worse by their job. And again, nurse assistants and nurses have the highest rate of non-fatal occupational illnesses and injuries compared to any other industry sector, including manufacturing and construction. So are you getting a hazard pay for what you're doing? Another contributing factor to injury are persons of size. And I know 40 years ago when I started as a acute care occupational therapist, if I had a 300-pound patient, we thought that was large. Well, now it's not uncommon to have patients that are 500, 600 pounds. And we want to honor the dignity and worth of our patients, but we also need to have the tools to be able to care for them. In 2014, 67 to 80% of people in the United States were morbidly obese or overweight. We look at, our overweight folks have a body mass index, a BMI of 25 to 29.9. Obesity has a BMI of 30 to 39, and those morbidly obese have a BMI of 40 or higher. So how do these low back disorders develop? It's cumulative in nature. The good Lord gave us curves of posture, and we know we have our vertebrae, and in between the vertebrae are our discs. Fun fact for the day, there's no such thing as a slip disc. That's like fingernails on a chalkboard to a therapist. But you can have a bulging disc, a ruptured disc, a herniated disc, or a desiccated disc, but there's no place for that disc to slip. So what happens is in your day-to-day care of patients, when you're bending and reaching and twisting and pulling, you're incurring microfractures to the end plates of those discs. The spinal nerves don't go to the inside of the discs. They're on the outside of the disc. So then those microfractures lead to scar tissue. Scar tissue leads to nutrient deficiency, which leads to disc degeneration, which leads to decreased tolerance and capacity. If I would do MRIs on all of our wisdom workers, we will show changes in our discs. That happens as you age. You may notice that when you go to a family reunion that Aunt Mary or Uncle Jeff appear to be shrinking. As we age, our discs lose their height, they lose their viscosity. A safe work practice that you can incorporate into your day-to-day routine is always raise the bed so that your elbows are at a 90-degree angle. And when you are forward bending to care for your patient, afterwards, stand up and put your hands on your hips and do a gentle backward bend. I know many nurses have experienced sciatica, that shooting pain that goes all the way down your butt to your great toe. That forward bending pushes the disc back against your spinal cord. But when you do gentle backward bending, it helps push the disc forward away from the spinal cord. Fun fact for the day. So there's different types of force. There's compression force, which is straight up and down, and then there's shearing force, which is forward or backward. And Dr. Bill Maris from the Ohio State University has done some of the earliest research in terms of what's the impact on your discs with patient handling. And if you look at the spine forces, again, we can lift something straight up and down with a higher tolerance, 3,400 to 6,400 newtons. But when you are moving anterior or posteriorly, your shearing forces are only 1,000 pounds of newtons, and then your lateral shearing, again, only 1,000 pounds. So you can, and if you think about it as a healthcare provider, as a nurse, when you're caring for your patients, we're not lifting them straight up and down. We're reaching forward, we're reaching backwards, we're reaching side to side. So biomechanically, we're at risk just because of the nature of how we were built. And that's another reason why it's really important that we look at how we work and how we use our body so that we can decrease our risk for those work-related musculoskeletal injuries. NIOSH, the National Institute of Occupational Safety and Health, they did the research. They looked at what could most adult workers safely lift in a box with good handles from hips to shoulder without exceeding those compression forces that cause disc disease. Most adult workers can safely lift 51 pounds in a box with good handles from waist to shoulder. But Tom Waters was a researcher, and he said, gosh, I think patients are different than boxes. Imagine that. How's a patient different than a box? They have extremities. They might be cooperative. They may not be cooperative. They may push against you. And it really doesn't matter if you drop a box, but it sure matters if you drop a patient. So there's a long formula, but what's important to know, the maximum amount of weight that any healthcare worker should safely lift in a controlled environment when the patient's cooperative, when the lift is smooth and slow, is 35 pounds, my friends. I can tell you, my leg weighs more than 35 pounds. So this really means that we should really think about how are we safely mobilizing our patients. And again, as an occupational therapist, I used to teach proper body mechanics all the time, head and shoulders upright, wide base of support, suck it, tuck it, keep it close, don't twist, and you won't get hurt. Well, with age comes wisdom, and with wisdom comes evidence-based practice. What I know now, I didn't know 40 years ago. It is inherently unsafe to manually move patients. So we really need to think about how we do what we do and what we can do differently. I know many nurses, I usually, again, use this analogy. How many of you remember when nurses used to recap needles? Nurses used to recap needles, but we don't do that anymore because we know it's unsafe for a bloodborne pathogen exposure. I remember when we didn't gown, we didn't glove, we didn't mask, when we would go into respiratory isolation. Why do we need to bunny up? We know now that when we have respiratory precautions, we need to gown, glove, and mask. I'm so old. I remember when they didn't foam in and foam out, and I was one of those babies that came home in the on my mama's lap in the front seat of the car, no car seat. But we know now that's inherently unsafe. So when we learn something is unsafe, we need to change practice. And I'm here today to hopefully push the cheese and get you excited and passionate about that we really need to use safe patient handling technology to keep you as a healthcare worker safe so you don't become the patient. Safe patient handling is really important too on the retention of nurses at the bedside. The average age of nurses now is 46, and we're facing a shortage of nurses, which is supposed to peak by 2020. If we don't change the way we work, our ergonomic environment, we're going to lose our wisdom workers, and we don't want to do that because our wisdom workers are the ones that bring so much knowledge and so much value to the bedside and mentoring our younger, newer staff. So I love this side. We give sanitation workers automated trash trucks so that they can empty their trash without hurting their back. But how do we mobilize patients? Let's just get 4 more people, 1, 2, 3 boost. So we really need to think about healthcare as an industry. I want you to think about using safe patient handling technology as your personal protective equipment to decrease your risk for incurring a work-related injury. I'm going to transition here into falls next, and then we're going to pull it all together. So this was from the Health Research and Education Trust, published in 2016. A definition of a fall is a sudden unintentional descent with or without injury to the patient, which resulted in the patient coming to rest on the floor or on or against some other surface, another person, or an object. So, and I know many healthcare organizations are very focused on falls. In fact, we became so fall focused that we stopped mobilizing patients, and now we have those complications from immobility that we really need to address as well. Significance of patient falls. Falls are the leading cause of hospital-acquired injury and can frequently prolong or complicate hospital stays. Between 700,000 and 1 million patients suffer a fall in U.S. hospitals each year. 30 to 35% of those patients sustain an injury, and approximately 11,000 falls are fatal. And falls have been identified by the Centers for Medicare and Medicaid as an acquired condition that should not occur. And this doesn't even speak to the significance of impact on nurses when their patient sustains a fall. We've done after action reviews, and it can be very traumatic when you have a fall on your watch. In 2016, the Joint Commission Center for Transforming Healthcare put together a Preventing Falls, Patient Falls project, and they looked at 7 U.S. hospitals. And this report, again, excellent resource, describes risk for falls, root cause for falls, and those risks and solution. And based on their intervention, they saw a 62% reduction in falls with injury and a 35% reduction in falls rates. Key takeaways for them were measuring and analyzing contributing factors and really looking at culture change. So we know that we can transform change by transforming our culture. Top factors and issues that contribute to patient falls: not having a fall risk assessment, a poor handoff in communication, toileting, call lights, education and organizational culture, and medications. So again, it's not one thing in particular that causes a fall, but all of these factors integrated together. What we've incorporated with part of our fall intervention is really looking on the mobility assessment and documenting that on the whiteboard using a consistent language. And what I can share a bad experience, we had used one of our floor-based lifts is an Easy Way product, and the associate had written on the whiteboard that the person was an easy lift, not realizing that the healthcare provider thought, oh, this person is an EASY lift. So our lesson learned from that is when we use our mobility assessment, we're using consistent language on the whiteboard. Is the patient independent, up with supervision, up with 1 or 2 person assist with a gait belt, using a stand assist device, a floor-based lift, or are we just looking at bed into chair position? So again, lesson learned in fall management is how are you communicating that with your team. Other parts of our fall integration is really looking at a fall risk education for every patient on admission and throughout the stay, placing fall prevention handouts in patient education folder, and signage, call don't fall in the room and in the bathroom. And we've even moved forward to staying with patients in the bathroom because we've seen so many falls related to toileting. We also need to communicate to the family members that many times they don't realize that their loved one might have a fall risk. So really providing that education from the get-go, and that can be a benefit in terms of reducing your falls. When we look at best practices, they're complex and multifactorial. There is no magic bullet. It's not one thing, or we'd all be doing it. What we see that really makes a difference is organizational support for falls reduction across departments and disciplines. It needs to be anyone who touches a patient. Transparency of fall rates, accountability through auditing compliance with fall risk assessments and interventions are all collectively best practices for fall prevention. There are additional best practices for fall prevention. Looking at your fall risk assessment, there are many different instruments that are out there. Some are better than others. You may be using the Schmid, you may be using the Morse, you may be using the Hendricks, but really making sure that you do have a fall risk assessment. Using visual identification of patients at high risk for falls. It's more than just yellow socks and yellow bands. Fall risk factor directed interventions based on a person's fall risk, having different levels of intervention based on whether they're a low fall risk, a medium fall risk, or a high fall risk. Standardized multifactorial education with visual tools for staff, family, and patients. Teach back with patient education. We know that the bedside nurse has a significant impact on patient education. And then the interdisciplinary collaboration. So it's anyone who works with that patient. Wanted to also shout out about fall retrieval. If a patient has already gone to the floor, stop, take a breath, and then go get a floor-based lift to get the patient up off the floor. If you need to put them on a spine board, if you need to put a cervical collar on, there are full body slings that can be used with your portable lifts, and that's a much safer way to get a patient up off the floor rather than 8 people in a sheet. Adding more people does not distribute the risk adequately. Somebody is always going to get hurt. So let's segue back into what is safe patient handling. I talked a little bit about the risk. I've talked a little bit about falls, but now I really want to hone in on patient handling. Manual patient handling, that's what you're currently doing, just that snagging and dragging, transporting or supporting a patient by hand or bodily force, pushing, pulling, carrying, holding, and supporting that body part. But safe patient handling, this is that evidence-based approach to reducing risk to caregivers. It includes a risk assessment, use of your equipment or technology, a patient assessment, algorithms, peer safety leaders, and after-action review. The the safe patient handling journey really started about 20 years ago in the early 2000s, and Audrey Nelson from the Tampa VA was one of the key stakeholders in the very beginning, and she is well published and well documented regarding safe patient handling. So why do we do safe patient handling? Patient benefits, improved quality of care, improved mobility, reduced risk of pressure injury, and increased satisfaction. And I don't know about you, but I know we're looking at HCAHPS in our healthcare system, so that makes a difference. Healthcare worker benefits. Why should we use safe patient handling? Wouldn't you love to have more energy at the end of the day? Improve the quality of your work life for your staff by decreasing the risk for musculoskeletal injuries? Reducing injury rates among healthcare staff, retaining healthcare staff at the bedside, those wisdom workers, and then again, decreasing workers' compensation costs. These are all reasons that we should integrate safe patient handling into our day-to-day healthcare. Again, when we look at evidence-based strategies for a comprehensive safe patient handling program, this is the work of Audrey Nelson and the Tampa VA. You start with an ergonomic assessment protocol, because if you're in the ICU, your patient handling needs are going to be different than if you're med-surg versus OR versus ED. Patient handling assessment criteria and decision algorithms, they've done the work. We can access their work, and so you don't have to start from the bottom. Peer leaders, those are your go-to people who become the coaches on your unit. They are your super champions. They are the ones that are going to influence the behavior to utilize safe patient handling technology. You do need to have state-of-the-art equipment, and you need to be aware of changes in technology. After action reviews, part of my role as the on-site occupational therapist, whenever there was a patient handling injury, I would call the associate and do an after action review and tell me what you were doing. Tell me more. Was technology available? Did you use the available technology? If not, why not? And that's where we really learned that many times technology was available, but the associate didn't take the time to go get the technology. So we know that we need to have available technology that's easily accessible and that everyone knows how to use it. And then having a policy. Our policy, it recommends minimal lift, not to engage in manual lifting and to utilize those algorithms, but we do not have a punitive policy. There are some healthcare organizations that will actually say, if you get injured on the job and you don't use lift equipment or lift technology, then there can be repercussions for that. That's not what we do, but I just wanted to throw that out there. These are the ANA Interprofessional Standards of Safe Patient Handling and Mobility, and they actually came out in 2013, and I'm excited to say that Ruth Francis, who's on the ANA, is working to facilitate a revision of the Safe Patient Handling and Mobility standards to also address falls, and I'm working on one piece of that as well. So very exciting. And what I loved about this, it was interprofessional. They had OTs and PTs and ergonomists and safety people and nurses and involved in the creation of these national standards. And the first standard is 1, establishing that culture of safety. And then 2, implementing and sustaining a safe patient handling and mobility program. 3, incorporating ergonomic design principles to provide a safe environment of care. 4, selecting, installing, and maintaining safe patient handling technology. 5, establishing a system for education, training, and maintaining competence. 6, integrating patient-centered safe patient handling assessment into the plan of care and use of safe patient handling technology. Again, if we go back to that mobility as medicine, a culture of safety, if we mobilize early, if we mobilize safely, we're going to decrease risk of falls, decrease risk of skin injury, and decrease risk of patient handling injuries. In my role as the on-site occupational therapist, we use safe patient handling as a reasonable accommodation in returning people to work. If they had lifting restrictions, could they use technology and still be at the bedside? And then the last standard is establishing a comprehensive evaluation system. At Ohio Health, what we look at are the number of patient handling injuries, the costs associated with those injuries, and we're actually using the patient classification that was created by Aon to really track the mechanism of injury more specifically. So Aon has created a list of 20 different categories of patient handling injuries. And I can tell you that based on my experience, our most frequent patient handling injuries that boost, turn, and reposition, followed by the lateral transfers, followed by bed to chair. So again, using that Aon classification can help you target in where's your most frequent injury, and is that where you want to start. I had the pleasure, I mentioned earlier, working with Inga Zedvinskas, who was my evidence-based mentor, and we actually did a nursing research study because I had been on my safe patient handling journey, and we had given some units safe patient handling technology, but gosh, even with my passion and desire to spread the safe patient handling word, they were still having patient handling injuries on that unit. And so Inga told me, let's go to the literature. Let's see what we need to do to really make an effective safe patient handling program. And that's when I learned about Audrey Nelson. I learned about the multifaceted approach to what you needed to have in a safe patient handling program. So there are administrative controls. That's your leadership support, having a budget, having campus representatives, and having a policy. There are behavioral controls. It's your education, your peer coaching, your whiteboard communication. And then engineering controls are your equipment, your maintenance, and your storage. And we did a trial. We compared two very similar med-tele units. One did not have any safe patient handling technology at all, and the other did have safe patient handling technology, but had only had the education that I provided and a unit-based educator. On our intervention unit, we actually created an 8-hour peer coach program where we taught them the risk factors of the why behind it, why it was important. We taught crucial conversations, and we used clinical scenarios, and we gave these peer coaches, who were nurses and PSAs, day shift and night shift, we gave them the tools to become the experts on their unit. We had them participate, get in the equipment, use the equipment, operate it, and then they had to return demonstration with other peers. And then we provided them ways to give feedback to their peers, so that if they caught them doing something right, it's always easy to give positive feedback, or if they needed to correct a behavior, what they could do differently. And so then we tracked the injuries of these two very similar med cardiology units over a year. And the unit that had the peer coaching, and we also created a policy. We didn't have a policy at that point. The intervention unit that had the peer coaching, the policy, and then again the technology, had a significant reduction in injuries compared to the unit that just had the lift equipment. So when you think about safe patient handling, you need to realize that it's way more than just having the equipment. It's a combination of administrative controls, engineering controls, and behavioral controls. And in my eyes, based on my work and my experience, I truly believe that the peer coaches made the significant difference. And if you're thinking about replicating that, it really looking at getting the right people in the roles to be those peer coaches. So then we went on and we now have an interprofessional committee. We've got a system committee. Each hospital has their own safe patient handling committee. And then we said we need to come up with some branding. We need to come up with a way to really recognize what we're doing for not just our associates, but for our patients and our families. So we branded our safe patient handling program and we call it Smart Moves, Safe Mobility and Responsible Transfers. So we have pictures of this is one the physical therapist Ashley Hurst is one of my program chairs at Riverside. And what we do is these smart moves are broadcast throughout the hospital on the computers throughout the hospital so that family can see them, patients can see them, and colleagues can see them. And then, because we want to honor the dignity and worth of each patient, when we have someone who might need assistance with using safe patient handling technology, rather than saying, hey, I need lift help in 2020, they'll say, hey, I need a smart move in 2020. So it really looks at using that equipment, providing that education to our patients and our families as well, that this is how we're going to move you safely, because it's all about safety. This dives down into our unit-based peer coaching. We've taken it from what used to be an 8-hour class, and we're lateralizing it as a 4-hour class. We involve PSAs and nurses, and we also have added rehab staff as well, OTs and PTs. We have unit champions. They reinforce the safety culture. And again, it's that hands-on experiential learning, working with clinical scenarios on their unit that's specific to them. By working on the unit, you can work through any time barriers or space barriers, and then facilitating that those peer coaches, they determine where do we want to place the equipment in this unit. And we now have fire code, life safety codes that will allow safe patient handling equipment to be out in the hallways. It used to be you couldn't leave any equipment out in the hallways because it was a joint commission, never. But they said, and it's well documented, that if your equipment is available, you're more apt to readily use that equipment. We also have moved forward with a mobility assessment tool. It's called the BMAT, the Bedside Mobility Assessment Tool. Prior to implementing the BMAT, we had many nursing units that waited to mobilize their patient until therapy was consulted. And again, that's pretty typical on some units. They want to wait. I don't want to mobilize that patient until therapy is consulted. But we said we know mobility is medicine. And if we're going to promote that culture of safety, our nurses see our patients before therapy is consulted, and many times therapy is never consulted. So what we look to the literature to find an assessment tool that could be integrated effectively and efficiently into the nurse's daily plan of care, so it's not one more thing. And this is a nurse-driven mobility assessment tool. It's 4 points. It's very easy. The first task is, can that patient, from laying down in bed, can they sit up and move over to the side of the bed, reach over and shake your hand? So they're looking at trunk control, cognition, and do they have the motor skills to do that? That's the very first part of the assessment. When you have them sitting up, you're assessing their grip strength. You can listen to their lower lung sounds. Great assessment. If a patient can't do that, then they're a level 1. And then you know that you're not going to get that patient out of bed unless you're using a dependent floor-based lift or a ceiling lift if you have that, or you're going to be working on in-bed mobility, just maybe bed and chair position. The second part of the BMAT is, if they are able to sit on the side of the bed, can they extend their leg and stretch and point? Here you're looking at quad strength, you're looking at lower extremity strength. And if they can't do that, then again, you go back to the lower level. But if they can do that, then at this point you might be able to use a powered stand assist device to get them up out of bed. Following level 2 is level 3. Can that patient stand? Can they get themselves up from the side of the bed? They can use their arms to push up, and can they raise their bottom up off the bed for a count of 10 seconds? And if they can do that, great. Then maybe you just need a gait belt or a walker. And the last one is, can they march in place and walk forward and walk backward? So what I really love about the BMAT is it tests the patient's functional mobility by observing tasks with increasing levels of difficulty. Because we know we've all had those little old ladies that they don't want to go to a sniff. They will overstate what they're capable of doing because they for fear of not being discharged to home. And then on the other end, we've had some patients that come in and they were walkie-talkie coming in, but then you got them up and it was like they were completely dependent. So the BMAT is an objective measure where you can really take them through. It's consistent, and you can use different types of visual management to communicate that. What I also love about the BMAT is it drives the safe patient handling technology based on the patient performance. Other benefits to the BMAT: we can reduce patient falls, we can communicate the patient's mobility to all staff. We can increase early mobility, improve patient discharge disposition because of that early mobility, decrease the complications from immobility. And we know complications from immobility. I mean, delirium, confusion, DVTs, deconditioning, and there's many, many more. And then we can also decrease staff injury related to patient handling. So again, looking at the BMAT, if they're a level 1, if they can't even sit up on the side of the bed and reach over and shake your hand, if we're going to mobilize that patient, we're either going to do in-bed mobility, maybe use an air technology or a floor-based lift. If they're able to progress to the next level, mobility level 2, you can always use you can always defer to more safety and use a floor-based lift, or you might be able to progress to the powered stand assist device. Mobility level 3, when they're able to stand up and get their bottom up off the bed, you can use a non-powered stand assist device or a rolling walker. Level 4, you can, at this point, they're able to march forward, march back. You can use a gait belt. A gait belt should never be used to lift somebody. It's just an assistive device that therapy uses with their patients, and that nurses can use for those patients that are a contact guard or walking independently. So you can see how the mobility progresses based on what the patient's able to do. Part of what we talked about early on in those standards is how do you maintain, how do you keep a program going? What's what's your process for sustainment? And we've used some safe patient handling incentives. We all love candy. When we've observed people using safe patient handling technologies, we've used those little Smartie candies and written their name on the back of the card and then put them in a drawing for a gift card to the cafeteria. There was, for Nurses Week, one care site really took the team theme and looked on Google and got lots of ideas to reinforce the use of technology by team building. If we do our peer coaching class, we always like to have the manager do a shout out as to why that person was selected, and then come to the class and really publicly acknowledge them. On one of our units, we had the nurses had an incentive to pull Foley's, because we know that was a best patient practice as well. So they could earn that golden float card, after they had pulled 10 Foley's, and they got the golden pass that if they were told to float, they didn't have to. So the techs on that same floor were like, hey, we don't pull Foley's, but what can we do to earn that golden float pass? And they were very creative and wanting to facilitate utilization of the technology. They came up with, anytime they were observed using technology, they would give them a punch, and when they had 10 punches, they too had that golden float pass. So incentives don't have to be expensive, but when you're trying to promote culture change, anything positive that you can do can make a big difference in helping to move the culture forward. Another part of safe patient handling and mobility and fall prevention is really looking at what do we do once we get them up in the bed, and current seating challenges. Does this look familiar to anyone that's C-sitting? And if the chair alarm's gone off, you're too late. Where we see the sacral sitting, we see airway and epiglottis compromise, body alignment, shear and friction, sacral pressure, frequent repositioning and potential caregiver injury, and potential risk for sliding out of a chair. There was a great study that was done by Guy Fragala and looked at the exertion of boosting patients up in the chair. And I know that we all do that on a routine basis. This study looked at 3 methods of repositioning a patient, and they used the Borg scale, which rated exertion, and then they saw that when they used this assistive device, it's called a seated positioning system, it was able to significantly decrease the exertion when boosting and repositioning a patient in a chair. So the seated positioning device, it has an air bladder, it has a one-way glide and a microclimate pad. So it decreases the force or the exertion when you're boosting, helps to promote proper ergonomics, redistributes pressure, and helps to manage moisture. And again, this can be a tool in your toolbox for those early mobility and progressive mobility. Ceiling lifts require 50 to 75% less force to push or pull than floor-based lifts. This was a study done by Dr. Rice up at the University of Toledo. Even if you use a floor-based lift, the torque required to move the floor-based lifts were 10 times more than ceiling lifts, again done by Dr. Rice. And then Dr. Maris has demonstrated in his research that the forces to move ceiling lifts are generally within a safe zone. So this is an example of a ceiling lift that can be used for progressive mobility in a rehab gym. Additional pieces of safe patient handling technology, single patient friction reducing slide sheets, the top one on the yellow one, that's an inexpensive tool that you can use when you're doing a lateral transfer, but it is friction reducing, so it's not breathable, so that's not something that can stay underneath the patient. We've got your lateral transfer boards. You're all probably familiar with the old smooth movers. The gait belts, they can be cloth, they can be buckled, different types of gait belts. And then reusable air-assisted transfer devices, those are ones that you can reuse, but you do have to log roll them from underneath and not leave them underneath. There's also now new technology, new air technology that you can leave underneath patients that has microclimate pads, and it's breathable so that we don't have to log roll them twice to get them out. So if we really look at pulling this all together, if we look at early mobility, because we know mobility is medicine, caregiver safety, if we use the right technology, skin safety, and fall prevention, we're going to really promote that culture of safety. In a safety culture for patient and healthcare workers, we can decrease patient handling injuries by decreasing repetitive motion injuries, decrease musculoskeletal injury, decreasing days away from work, staffing challenges, and loss of experienced nursing staff. With early mobility, we're going to decrease hospital length of stay, ICU length of stay, skin injury, caudate, delirium, and time on the vent. Pressure injury prevention, we can decrease skin injuries, decrease costs, decrease pain and suffering, hospital length of stay, and ICU length of stay. And then with mobilizing early and safely, we can prevent falls, decreasing falls with injury, and decreasing hospital length of stay. Again, that was from the work that I did with Dr. Black and Kathleen Volman. Okay, so this is all evidence-based. There are my citations. Thank you, Inga Zedvinskas, for making me an evidence-based person. This is my contact information. I am positively passionate about integrating safe patient handling, fall prevention, pressure injury prevention, and early mobility. If any of you have additional questions or want more information, feel free to reach out to me. I am a board member of the Association of Safe Patient Handling Professionals. I co-chair their education committee. We've got some great webinars that really look at safe patient handling across the continuum of care. Another great opportunity. Legislation, we currently have 11 states that do have legislation mandating safe patient handling programs. California, Illinois, Maryland, Minnesota, Missouri, New York, New Jersey, Rhode Island, Texas, and Washington. Ohio has legislation, but it's not as comprehensive. Ours only has to do with granting loans for nursing homes to purchase equipment. So lots of content out there, lots of information. Are there any questions?
If anybody has questions, you can type it in the question box or in the chat box.
Did we solve the mysteries of the universe? Did we meet those objectives? If I go back, are you
Oh,
able to identify the relationship between caregiver safety and patient safety? Do we have a question?
we do. Okay, so
Oh, good. I love questions.
what are some suggestions for going from a climate of blame to a climate of prevention of injuries?
That is a great
It
question.
is.
I think one of the first things you need to do, you can work with your associate health department or your employee health department and look at where the injuries are, working with your safety to get a baseline, and then really bringing up the whole subject of just culture and culture of safety. And again, we need to look at the evidence, and when we know something's unsafe, we have to change practice. And it can't be a blame game. It's got to be, how can we work on this collaboratively? And I'm going to tell you, it is not easy. I've been on my journey for 15 years, and even though I'm recognized as a national subject matter expert, we're not where we need to be. You know, it takes time to change culture. Was that a adequate response?
I thought it was a good answer, and it was definitely a great question. Carol said thank you. Thanks, Carol, for the question. Anybody else have any questions, comments, concerns?
And Jessica, do you give them a copy of this presentation so that they can have access to it through a PDF?
I definitely can if you're okay with that.
I'm absolutely okay with that. I'm
Awesome.
very much a person of sharing the knowledge because we're small but mighty, but we've got to get the message out. Most frontline healthcare workers don't understand the inherent risk of injury, and we really need to stop siloing and really integrating early mobility, falls prevention, skin injury prevention, and safe patient handling.
Yeah, I mean, it all goes hand in hand. And so you won't achieve all of those things if everyone's working separately on just their area. They all affect, one affects the other.
Yeah, at Ohio Health, we've recently initiated what we call the system safety trifecta. So we have our early mobility folks with the BMAT, we have me with safe patient handling, and then we've got our falls prevention. I wasn't able to get skin to the team yet, but we're really looking at working collectively, looking at visual tool management, looking at how we can get that consistent message out, and it's exciting. It's the right thing to do. And there's also a national safe patient handling and falls conference. The next one is in Orlando in June. It is an outstanding conference. It is just, you can see all the vendors, all the technology, and you have access to national and international subject matter experts that have been on this journey. And some are going into, clinical case scenarios. There's a rehab track, there's a falls track, there's a nursing track. It's an outstanding conference that I highly recommend.
Yeah, it sounds awesome. Yeah, I'll definitely email out those PDF of the slides to everybody who attended. And if you're watching this enduring, then you have the PDF of those slides as well. So thank you, Susan, for that.
My pleasure. Is there anything else I can do for y'all?
I don't see any other questions. So if everybody's good, we can go ahead and close out the webinar. Definitely, if you think of a question after the fact, email me or Susan. We can get that answered for you. And thank you guys for coming. Don't forget, if you want your contact hours, to fill out that evaluation.
Super. Thanks so much, everyone. Have a thankful Thursday. Bye now.